Welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Dr. Sabyasachi Gon to start this session. Thank you and over to you, sir.
Hello, good afternoon, everyone. So today's topic is one of the most favorite topic of post-graduation and also of year otology. So topic is for discussion today is otosclerosis. So otosclerosis is defined as a primary progressive disease of the labyrinthine otic capsule with due to the new bone formation in the otic capsule, which is characterized by hearing loss and sometimes with tinnitus and vertigo. So the exact etiology of the otosclerosis is not known, although many theories have been postulated. They are hereditary, endocrine, metabolic, and vascular factors. So coming to hereditary factor, there is a growing evidence that suggests that it to be a heterogenetic disease due to the involvement of more than one genetic defect like chromosome 15q or gene defect COL1A1. In endocrinal, similar kind of lesion can be seen in different disorders, bone disorders like osteogenesis imperfecta, Paget's disease of the temporal bone, Camurati Engelmann's disease, which is also known as progressive diaphyseal dysplasia, etc. And if we go to the viral causes, paramyxovirus may likely be the cause of Paget's disease of the temporal bone. We know the measles is caused by the paramyxovirus. Electron microscopy shows measles-like structures in active otosclerotic focus, and immunohistochemistry also shows measles antigen in active foci. It has been also suggested that autoimmunity is important for otosclerosis or as a hypothesis for formation for otosclerosis, and type 2 collagen antibodies have been found in patients of otosclerosis. Coming to another thing about measles virus, elevated levels of IgG antibodies to the measles virus is also seen from the perilymph fluid. So prevalence of otosclerosis in our society is from 0.1 to 1%. Average is about 0.3%, whereas histologic otosclerosis is 10 times more than the clinical otosclerosis. So what is histological autosclerosis? When there are no clinical symptoms, but it can be discovered by routine sectioning of the temporal bone of autopsy. I hope this is clear. There are two types of autosclerosis. One is histologic autosclerosis, another is clinical autosclerosis. So clinical autosclerosis, the incidence or the prevalence is 0.1 to 1%, average is 0.3%, and histologic autosclerosis is 10 times more than the clinical autosclerosis, where it has been seen in autopsy it can be discovered by routine sectioning only, but they do not have any clinical symptoms. It is more seen in Caucasians, less in Asians, though in Toda community of India, this is prevalent. And the incidence about prevalence is about 17 to 19%. And it has been postulated that due to the consanguineous marriage that happens in Toda community, the otosclerosis prevalence is much higher. It is more in female. It's not 1:1 for female is to male, but it is actually 2:1. It aggravates during pregnancy, but the incidence of otosclerosis does not increase with repeated pregnancies. So there are different sites of involvement inside the otic capsule. The first and the most important site for involvement of otosclerosis is fistula antifenestrum, which involves in about 80 to 90% of the cases. This is just in front of the oval window. The next important or the next common site is a round window, and it is very rarely occluded. Radiologically, round window otosclerosis has been classified from type 1 to type 5, and we very rarely see the type 5 where we see round window otosclerosis along with stapedial otosclerosis. They are confluent with each other. The next site of involvement is apical medial wall of cochlea, the posterior oval window, internal auditory canal, cochlear aqueduct, and semicircular canal. So otosclerosis Otosclerosis, the patient comes with different clinical features. The foremost feature is hearing loss. Hearing loss is they present in early or mid adult life. Usually it is third decade, and the hearing loss is usually bilateral. The hearing loss is a very special kind. Here, the in a noisy environment, the patient can hear better as a speaker speaks in a louder voice to be audible to himself and to the other people during conversation, and that increases that goes beyond the hearing threshold of the patient, and that's why the patient can hear better in a noisy surroundings. This is known as paraacusis of Wills. Patient also may present with tinnitus, and this happens more when there are active disease of otosclerosis, and Schwarz's sign can also be seen in otoscopic examination. Very few patients of otosclerosis present with vertigo, and this again happens during the active stage of the disease. Speech here is a very soft kind of speech, as patient can hear his own voice due to the masking effect. There is a family history available, and as we all know, there is incomplete penetration of the uh, incomplete penetration of hereditary effect. So family history is not always available, but it sometimes may be available. In otoscopy, usually the tympanic membrane is normal looking, but in active disease, we can see a pinkish glow in the more so in the posterior superior quadrant, which is also known as Schwarz's sign. In tuning fork test, we know there are Riene's test and Weber's test. Riene's test, we check the air conduction and bone conduction. In a patient of otosclerosis, the bone conduction is louder than the air conduction. So Riene is negative, and Weber is lateralized to the affected ear. As we all know that in otosclerosis, mostly we get a patient more of conductive deafness, and very rarely we get patients of mixed deafness or sensorineural deafness. That happens more so in cochlear otosclerosis. So in stapedial otosclerosis, where the deafness is more so of conductive deafness, here the Weber goes to the affected side, and it has got the significance also. While choosing which ear to operate, we check the Weber and also ask the patient which ear is worse, and if the hearing loss is more of conductive hearing loss only, and if one ear is more affected, the Weber goes to that ear. So we choose the ear where the Weber is directed. Now coming to Gilles test and the Bing test. In both the test, the bone conduction is examined, and both the cases, Gilles test and Bing test, in case of otosclerosis, it is negative. In Gilles test, what we do, we increase the pressure of the external auditory canal with the help of Siegel's speculum. That pushes the tympanic membrane inwards and thereby all the ossicles, and that pushes the inner ear fluid also, and the basilar membrane becomes fixed. So when we put the tuning fork over the mastoid area, when this is done, as everything is fixed, so there is no increase in sound. So Gilles test is negative here, and Bing test, the ear canal is blocked and the tuning fork is placed over the mastoid cortex, and it is tested whether the hearing is increased or not. As we know, in a patient of otosclerosis, there is already a masking effect due to the conductive deafness. So there is no extra effect happens after closing the ear canal. So in pure tone audiometry, what we see in early stage, there is only involvement of the low frequency. So we get a ladder pattern of hearing loss. The higher frequencies are less involved and the low frequencies are more involved. So airborne gap is more in the lower frequency and less in the higher frequency. This is also known as stiffness tilt. In a late stage, what happens when all the frequencies are involved, due to the mass effect of the otosclerotic focus, all the frequencies are involved, and so the airborne gap becomes more of flat in nature. Whereas in cochlear otosclerosis, we get either a mixed hearing loss or a sensorineural hearing loss. In most of the cases, we get in early stage of cochlear otosclerosis kind of auditory picture, where the involvement of the mid frequencies is more. So it will be something like this, something like this. So mid frequency will be more involved. The bone conduction or the cochlear reserve will be more affected in the mid frequency range. Carhart notch is basically a mechanical artifact. It's not, it doesn't indicate the actual cochlear reserve. So it starts, it's actually elevation of the bone conduction threshold, and it starts from 500 hertz and goes up to 4000 hertz. So it is about 5 decibel in 500 hertz, 10 decibel in 1K, and 2K it is about 15K, and at 4000 it becomes again 5K. So this is a loss of bone conduction that we can see in audiometric picture, but as I already said that this is a mechanical artifact, and this is corrected after doing stapes surgery or stapedotomy surgery. Why it happens? Previously it was thought that this is due to ossicular inertia, but theory which is now postulated that the ossicular inertia happens mostly at 800 hertz, but we can see that the maximum elevation of the bone conduction threshold happens at 2K hertz, which is more happens during ossicular resonance. So Carhart's notch now postulated that it is not due to ossicular inertia but due to the ossicular resonance effect. Now coming to impedance audiometry, which was discovered by Jarger in 1960s. So different curves has been postulated, and impedance audiometry is nothing but the response of the middle ear to a sound stimulus, mechanical energy in the form of sound stimulus. What kind of curve we get in otosclerosis? It's mostly A curve, and in some cases we get a S curve, and also in very limited number of cases we get a D type of curve. The most important thing in impedance audiometry is static compliance. What is that? We know there is a peak compliance in an otosclerotic patient where the middle ear pressure is almost equalized to the atmospheric pressure. So this is actually zero atmospheric pressure. The peak compliance happens at zero atmospheric pressure. That's why the curves are A, AS or AD. The static compliance is defined that the peak compliance minus the compliance at 200 plus 200 decapascal. So this ranges from 0.3 to 1.6 cc or ml. Now, if it is more than 0.6, that means the focus will be a thin kind of focus. Otosclerotic focus will be thin kind of focus. But if the static compliance is less than 0.2, that means that we mostly the chances will be higher that probably we are dealing with a case of obliterative otosclerosis, which I will come later on. So next important thing in impedance audiometry that we should look after is acoustic reflex. Acoustic reflex, as we all know, that the afferent is by the vestibulocochlear nerve or the eighth cranial nerve, and the efferent is by the seventh nerve. It is due to the contraction of the stapedius tendon. So, acoustic reflex is lost ipsilaterally in early cases of otosclerosis, and in late cases both the ipsilateral and contralateral both are lost. There is another term is non-acoustic reflex. What is that? Non-acoustic reflex is a kind of subtle reflex and which gets adapted very easily. So how this is generated? This is generated either by gently tapping the tragus of the ear being tested, or a jet of cold air over the cornea ipsilaterally. So what happens? There is contraction of the tensor tympani muscle. All right. So this is known as non-acoustic reflex. What is the significance of this non-acoustic reflex? Because we know that otosclerosis, there is fixation of the stapes superstructure at the foot plate region. But there is differential diagnosis also. Another is malleus ankylosis of the malleus. So malleus ankylosis, if there is the acoustic reflex is absent and non-acoustic reflex is present, that means the fixation is at the level of stapes. But if the acoustic reflex and non-acoustic reflex both are negative, that means there will be a fixation there may be fixation at other levels also. Maybe the fixation is not limited to the stapes, maybe it is extended to incus and malleus also, which may happen in tympanosclerosis. All right. So coming to the investigations, there are other investigations apart from audiometry and impedance audiometry. Third test which is important is speech audiometry. So in speech audiometry, two tests are important. One is speech reception threshold or spondy reception threshold. And usually they match the average of pure tone average of 500, 1K and 2K conduction threshold. So speech discrimination score is calculated after knowing the speech reception threshold. Some words were presented to the patient and a score is generated. It actually says more about the prognosis of the surgery of otosclerosis. And there are many references which says that we should not operate if the score SDS score is below 70%. So when this score goes down, if there is loss of cochlear reserve, that means if the bone conduction also goes down, if it is not a pure conductive hearing loss, if it is a mixed hearing loss, then the SDS score will be lower, on the lower side. If it is a pure sensorineural hearing loss, again the speech discrimination score will go down. So now coming to the vestibular test, whether they are necessary or not. There are three kinds of dizziness patient, vertigo patients seen in otosclerosis. In type 1, the patient complains of sense of imbalance or some kind of rotatory movement. In type 2, the patient complains of sense of rotation. In type 3, it is more or less synonymous with the endolymphatic hydrops or Meniere's disease, where the patient complains about hearing loss, fluctuating hearing loss, roaring tinnitus along with vertigo. Imaging test, CT scan shows if the focus is more than 1 millimeter in size. As we all know that the otosclerosis involves the otic capsule, which is the most dense bone in the body. So CT scan cannot differentiate between a otosclerotic focus and the otic capsule. So what it actually picks up is the size of the focus. If the size of the focus is more than 1 millimeter, and it happens in inactive phase, because in active phase there will be osteoclastic activity, and in osteoclastic activity the focus size will not be more. So the CT scan is important more in inactive phase, where the size of the foci is more than 1 millimeter in size. So coming to cochlear otosclerosis, this is a special kind of otosclerosis which is a gradually progressing sensorineural hearing loss due to the direct or indirect enzymatic action of the otosclerotic focus on otic capsule. Here, the hearing loss is bilateral, symmetric, but the hearing loss here will not be pure conductive in nature. It will be mixed hearing loss or sensorineural hearing loss. Females are more affected than the males, and the pure conductive and it's very this kind of otosclerosis is very difficult to diagnose. The incidence is about 20 to 30% in case of gradually progressing sensorineural hearing loss patients. This 20 to 30% is not amongst the patients of otosclerosis, but this, if we take 100% of gradually progressing symmetrical hearing loss, sensorineural hearing loss patients, there we can have 20 to 30% cochlear otosclerosis patients. In pure cochlear otosclerosis, tinnitus is a presenting symptom. So, how to diagnose? A positive family history, the hearing loss aggravates or starts during pregnancy or with uh, oral contraceptive pill. The patient presents with sensorineural hearing loss, tinnitus, vertigo, and sometimes Schwarz's sign is present. Schwarz's sign is active pinkish glow in the posterior superior quadrant of the tympanic membrane. So, as I already said, the audiometry shows a cookie bite kind of audiometry, and the SDS score, the speech discrimination score, will be on the poorer side. Here, one important thing is to see is the stapedial reflex will be present, but we know that in otosclerosis patients, stapedial otosclerosis patient, the stapedial reflex is lost very early, ipsilaterally, and in late stage, both ipsilaterally and contralaterally. Endolymphatic hydrops is a complication of cochlear otosclerosis in about 6% of the patients. So, what are the treatments? Treatments either medical or surgery. So, medical will be in the form of sodium fluoride. Surgery can improve the hearing to a level where hearing aid can be used. That is the only purpose of surgery, nothing else. So, coming to the differential diagnosis of otosclerosis, there are different kind of disease which may present as otosclerosis, look like otosclerosis. One is serous otitis media, where we know that the middle ear cavity is filled up with weight. Adhesive otitis media, tympanosclerosis, malleus ankylosis or fixation, ossicular disruption, but usually ossicular disruption is monaural, not binaural. Here in otosclerosis, we know in most of the cases the hearing loss is bilateral. Congenital stapes fixation, this can be unilateral or bilateral both. Congenital cholesteatoma, again this is mostly unilateral, very rarely this can be bilateral. Superior semicircular canal dehiscence, again this is usually unilateral in nature. The patient presents with conductive hearing loss and dizziness, very rarely with tinnitus. So, what are the treatments? Coming to treatment, treatment is non-surgical or the medical and the hearing aid. So, medical treatment when there is active disease. That means the patient presents with hearing loss along with tinnitus and vertigo, and we can see a Schwarz's sign, then a sodium fluoride can be given as a medical treatment. Each and every patient of otosclerotic patient should be counseled or informed about the alternative mode of treatment apart from surgery, that is the hearing aid. You must inform the patient regarding the option of hearing aid before proceeding for the surgery. Now it's up to the patient which treatment option he or she is going to choose. For surgery, the indication is airborne gap. It should be more than 25 decibel of airborne gap, and SDS score should be more than 70%. Contraindications are absolute and relative. So absolute contraindication, when the presenting ear is the only hearing ear. You must not attempt any stepis surgery in single hearing ear, single ear. All right. If it is the only hearing ear, you should not attempt stepis surgery in that ear, but you should give a hearing aid to the patient. Now, there are other relative contraindications also. If there are active middle or external ear infection, that should settle down first before proceeding for stapes surgery. If there is middle ear atelectasis, then the stapes surgery should not be attempted. If there is Schwartz sign is positive, that means active otosclerosis is there. So you should wait till the active stage goes down, and then we can offer the patient the surgery for otosclerosis. If the patient is having vertigo and tinnitus, we should wait till the subsidence of the symptoms. In case of pregnancy, in case of other medical diseases, this should not be done. And for some professions like wrestlers, boxers, the people who are in more in contact game like kabaddi, football, they should not go for this surgery, but they should wait when they can opt out of the sports or the profession they are in, and after that this should be surgery should be done. The informed consent is a must, is an absolute for stapes surgery, because we all know the most important complication after stapes surgery is sensorineural hearing loss, and we must inform the patient about the this problem, about this complication of stapes surgery, that this might happen. And if after knowing this patient agrees for the surgery, we should take up the patient for surgery. So stapes surgery is a perfect example of an elegant combination of art and science. So let's go back to more than 1 century back, where first this stapes surgery was attempted, which is also known as era of mobilization of stapes, which was first attempted by Kessel and Bocheron in 1878, and Miotte also attempted this in 1890, where they tried to mobilize the stapes by mobilizing the anterior crus, and for some time, for some duration, the patient heard well, and after that again it was involved with the otosclerotic focus and the hearing went down. But the complication was that many patients developed sensorineural hearing loss. So in international conference, the decision was taken that the mobilization of stapes will not be attempted. But this again was taken up by Rosen in 1952. Coming to the second kind of surgery which was attempted for otosclerosis is Lempert's by Lempert, and which is also known as Lempert's one-stage fenestra non-ovalis surgery, where a third window was created after doing mastectomy, and a fistula was created over the lateral semicircular canal, and then the patient heard with that window. But this surgery has got many complications. This had complications of a mastectomy complication. Along with that, there are very severe dizzinesses were present with the surgery. So this was not popular. Then come the era of replacement of the stapes with artificial prosthesis, which we do now after many advancement of the actual surgery that was advocated by John Say in 1958 and 1963, which was stapedectomy, which was further elaborated by different ways by different authors, Suknet in 1960, House in 1960, and Portman in 1961. The surgery was later modified by Kose and Kose in 1984 and Coletti in 1994. So what is stapedotomy? In stapedectomy, we know that the whole of the foot plate of the stapes was removed, and then a graft was placed on the foot plate, and an artificial prosthesis was uh, inserted into the long process of the incus, which connected the foot plate of the stapes, and it sat over the graft. Now in stapedotomy, this operation has got many complications. Most of the complications were sensorineural hearing loss and dizziness. So a neurosurgery was advocated, keeping the principles as before, by causae and colati, but less than 25% of the foot plate of the stapes were removed and a prosthesis was connected from the long process of the incus up to the foot. There were newer advancements also, where different authors from different parts of the world tried preserving the stapedius tendon. Some sectioned the stapedius tendon, and after the surgery, they use adhesive to connect the stapedius tendon along with the posterior cross. And some authors also tried keeping the stapedius tendon and the inferior joint intact while doing this surgery, which is also known as neostepidotomy. So coming to stapes surgery. Yeah, coming to stapes surgery. So before coming to the actual surgery, let us discuss about the anesthesia. So what are the preferred modes of anesthesia? There are two modes of anesthesia that is used in otosclerosis patient. One is local anesthesia, another is general anesthesia. Different surgeons have their own perspective. Local anesthesia has got one benefit, that the surgeon can check the hearing improvement on OT table, and he can also check the length of the piston by inserting, and if the patient complains of dizziness, then he cuts a part of the prosthesis, and a shorter prosthesis is used if the patient complains of dizziness. But GA is preferred for a struggling patient, a non-cooperative patient, or patient who doesn't want to get operated under local anesthesia. And there are some surgeons also who doesn't want to operate under a patient under local anesthesia. So what are the routes? Routes are different routes. One is there are two routes that were preferred. First, let us discuss what are the instruments that can help us in performing the surgery. Instruments means what are the scopes that we can take to do the surgery. One is microscope, another is endoscope. When the surgery was started, this era of using this artificial prosthesis, everyone used microscope. So nowadays we know that after the advent of the autoendoscope, many surgeons, including me, are very much comfortable of doing endoscopic stepidotomy, and we are more comfortable in doing endoscopic stepidotomy than microscopic stepidotomy. So in microscopic stepidotomy, there are basically two routes. One is transcanal, another is endoral. So in transcanal, a speculum is used with or without holder. Again, there are authors or surgeons' preferences. Some people uses a speculum holder just to so that they can use both their hands, and some people are more comfortable with doing the surgery in one hand only. In endoral, there is a endoral incision is made, and the retractor is used to open up the external auditory canal, and this gives us a better view than the transcanal approach. But this is not done by many authors who favors the transcanal approach. Now, in endoscopic ear surgery, endoscopic stepidotomy, as you know, that it is always transcanal. So stepidotomy by endoscopy is by all means it is a endoscopic transcanal stepidotomy. So in all these three routes, the incision made over the external auditory canal, the bony part of the external auditory canal, is Rosen's incision. But we advocate not to make the original Rosen's incision, but do a modification. In original Rosen's incision, the width of the flap is smaller, but we know in case of otosclerosis patient, we need to curate or drill the posterior superior bony overhang, and in some cases this drilling or curating is very much, so the tympanomeatal flap may fall short. That's why the width of the flap should be moved. So at 9 o'clock, the flap width should be more than 10 millimeter in size. That is our modifications. Now, after giving the endometrial incision, the tympanometal flap is elevated. Now, elevated till the fibrous annulus. Now, the annulus is lifted from the bony annulus and middle ear is exposed. Now, the bony annulus along with the posterior superior bony canal wall is either curated or drilled for getting a better view of the incudo-stapedial complex. So, how much should we see? And posteriorly, we should be able to see the stapedius tendon, the pyramidal eminence, and the base of the pyramid. Till the base of the pyramid, the visualization should be made. And above, you should be able to see the tympanic segment of the facial nerve or the horizontal facial canal. In endoscope, sometimes what happens when we started early, we were able to see the incudo-stapedial complex by rotating the endoscope a little bit anteriorly and looking towards posteriorly, and we were able to see the areas. But when we tried to insert the piston or the prosthesis, it was difficult. So in endoscopic stapedotomy also, the removal of the posterior superior bony canal wall or the bony annulus area is similar that is being done in microscopic ear surgery, so that the prosthesis insertion becomes easier or handling of the instrument to the footplate area becomes super easy. Now, chorda tympani nerve is one of the important nerve that comes in picture after elevating the fibrous annulus along with the tympanometal flap and the tympanic membrane. We can see the chorda tympani nerve. So, chorda tympani nerve, we should try our best to keep this intact, not to injure this, not to stress this. So, it is elevated from the posterior bony canal till its departure from the facial nerve, and we should try to save it. But in some cases, this is not possible. So it is better to cut the chorda tympani nerve than to stretch it, because stretching it gives more problem to the patient. The patient complains of dysgeusia or different test in the post-operative period. So next thing is after exposure, which comes when we can see the incus, long process of the incus and the stapes superstructure. We should check the ossicular chain, whether they are intact or not, whether they are mobile or not. So each and every ossicle is palpated and looked for their mobility, malleus, incus and the stapes individually. After that, the ossicular chain is checked for its mobility by moving the malleus, and we can see, if we can see that the incus is mobile, malleus is mobile, but not the stapes, our clinical diagnosis of otosclerosis is confirmed now. Now, in conventional and reverse stapedotomy or reversal of steps, these are the two methods of doing stapes surgery. Both the methods up to this remains similar, but after that, in conventional, what we do, we section the stapedius tendon near the pyramidal eminence, so that no part of stapedius tendon remains in the middle ear. But the surgeon who want to construct the stapedius tendon after inserting the piston, there the cutting of the stapedius tendon near the neck of the stapes is advised. After resecting or sectioning the stapedius tendon, the incudo-stapedial joint is dislocated with a 90-degree pick, followed by posterior crurotomy, which is done by 2-3 methods. First is by a pick. The stapes superstructure is moved towards the promontory and both the crura get fractured and this is removed. In some surgeons prefer drilling the posterior crus with uh, a micro drill or a Skeeter's drill. Some surgeons prefer vaporizing it with a laser. So there are preferences, different preferences by the different surgeons. Now, after removing the posterior stapes superstructure, we can see the footplate area properly. Now, the mucosa is excoriated. This step may invite some bleeding, which should be controlled with putting some gel foam soaked with adrenaline, and then we should go for the actual surgery. So before putting the measuring before cutting the piston or the prosthesis to its size, we should measure the distance from the medial surface of the long process of the incus up to the foot plate, and an instrument is used here which is known as gauge. So stapes gauge is used to measure the distance, and the distance which we get, we should add 0.5 to it to make up the distance of the focus and up to the till the piston reaches the oval window in the perilimb. So if the distance is 3.75, then 0.5 is added. So actual length of the piston that to be used, it will be 4.25. So after that, a control hole is made in preferably in the center of the posterior quadrant of the foot plate, and then the hole is dilated, a connective tissue seal is used, and prosthesis is applied over the seal. Now, this surgery has got some drawbacks. This conventional technique has got some drawbacks. That's why method came, which was advocated by Ogofis in 1980 and 1982, which is also known as reversal of the steps or reverse stepidotomy. What happens here? We make a fenestra, we measure. Now, after exposure of the whole area, now comes the measurement. We measure the length of the piston required for the surgery. The length of the piston remains similar, measurement technique remains similar to the conventional technique. Now we make the fenestra with intact incudostapedial assembly. We are not cutting the stapedius tendon, we are not removing the stapes superstructure, we are not dislocating the incudostapedial joint, but with intact ossicular chain, we are making a hole or we are making a fenestra in the foot plate. Thereby, the floating foot plate, chance of floating foot plate is minimized. And after making the fenestra, we apply the piston. And after that, the other steps were followed. That means sectioning of the stapedius tendon, dislocating the incudostapedial joint, and then followed by crurotomy and removal of the stapes superstructure. Now, coming to a question that whether reverse stepidotomy is possible for all otosclerosis patient. No, that is not possible. If there is overhang of the facial nerve, ptosis of the facial nerve or the horizontal segment, there is dehiscence and facial nerve is hanging over the oval window area and thereby limiting the view of the oval window, then we might have to remove the stapes superstructure first, then we have to do the complete the surgery. In other cases where the view of the oval window area or the foot plate area is not proper, if there are variations of the anatomy of the foot plate, then we have to do the conventional technique. Now, coming to larger piston versus smaller piston. So, if all the authors 10-15 years back had agreed that 0.6 mm piston is the perfect size. But later on, different authors started trying 0.4 and 0.5, 0.5 pistons for doing this stapes surgery. And they had a result that the airborne gap closure in higher frequencies is better than the higher diameter, bigger diameter or the larger pistons. But in this patient, in lower frequencies, the airborne gap closure were not up to the mark like 0.6. But after a year, the airborne closure in this 0.4 and 0.5 becomes almost similar to 0.6. So nowadays, most preferred size is 0.5 piston for doing stapes surgery. Now, what are the problems and intra-op complications? So, when we were elevating the tympanomeatal flap, there may be a tear in the tympanomeatal flap, or while elevating the fibrous annulus. In this area, it happens mostly by the juniors, that while elevating the fibrous annulus, there is a tear in the either in the TM flap or in the tympanic membrane itself. It should be repaired immediately after doing the stapes surgery. You take a perichondrium or a temporary fascia graft and then put it underlay this and do it using the same setting. If there are incus problems, like there is incus is ankylosis of the incus is fake, ankylosis of the malleus, or incubomalleolar joint fixation, or there is some long process of the incus erosion, then we can do bypass technique in the form of IRP or TORP. IRP is incus replacement prosthesis, where the prosthesis is hooked to the handle of malleus. But not in all cases. If there is malleus ankylosis, in that case, head of the malleus is excised, incus is removed, head of the malleus is removed, and the prosthesis is applied to the handle of malleus. And TORP means total ossicular replacement prosthesis. These two problems can be done in incus problems. In dehiscent facial nerves, as we all know, facial nerve develops from Richter's cartilage, and due to the mal development of the Richter's cartilage, this dehiscent facial nerves may happen. In most of the situation, dehiscence can be seen, but this is not overhanging. Only there will be dehiscence, so we should be careful while instrumenting in this area. We should not injure the facial nerve. So surgery will be done smoothly. But if there is overhanging, then might be, as I said, that we have to do the conventional technique. The fist technique or the reverse stapedotomy is not possible. There are other conditions also, like the facial may be bifid or it may be coursing over the promontory, where we may have to discard the surgery. In obliterative otosclerosis, it is very difficult to identify the footplate area. So in this area, we have to drill the footplate area after, and it should be done by conventional technique. Again, this is not possible here. The reversal of steps is not possible. After removing the stapes superstructure, we have to drill the footplate area till we get a blue line. And after we get a blue line, the same techniques are followed. We have to measure the distance, then we have to make a control hole, and then we have to make fenestra and apply the prosthesis. So round window otosclerosis is a common phenomena. It's not an uncommon phenomena, but in very rarely we get round window otosclerosis which obliterates the round window, and in those cases the surgery should be abandoned. Otherwise, you can proceed for the surgery. Persistent stapedial artery. As we all know, the stapedial artery atrophies by the 3rd month of the fetal life, and if it is persistent, which is very rare, it starts from the anterior inferior corner of the middle ear, from the internal carotid artery, and then it courses near the anterior cross of the stapes, and then it goes through a channel and goes and meets up to the middle meningeal artery. The patient also complains of pulsatile tinnitus along with hearing loss. This is more seen in trisomy 13 and 15. In these cases, if a traumatic surgery is possible, we should go with the surgery. As I said, the artery moves from the anterior inferior direction and it goes anterior to the anterior cross. So if you can manage, because we are making fenestra in the posterior quadrant of the foot plate, so if it is possible to do the surgery without injuring the stapedial artery, because if you injure this will be vigorous bleeding. So without making any trauma to the stapedial artery, if the surgery is possible, we can go for it. But clamping of this stapedial artery, there is a theoretical discussion that it can lead to contralateral hemiplegia as it is connected to the middle meningeal artery. So this is not advocated. Malleus ankylosis, the incidence is about 1%, and in patients of malleus ankylosis, otosclerosis is present in about 75% of the patients of malleus ankylosis. So what we should do, as we already discussed, we have to remove the head of the malleus incus, and then we have to do incus replacement prosthesis. We have to hook the prosthesis into the handle of the malleus, or we can go for the total ossicular replacement prosthesis. Now coming to CSF or perilimb gusset. In true sense, this is actually CSF gusset. When we make the fenestra, a huge amount of fluid comes out from the oval window area. And this happens due to the patent cochlear aqueduct or abnormality of the fundus of internal auditory canal. This is present in 0.03% of cases. All right. So if there is, and this can be picked up in HRCT temporal bone, they can give us a clue that yes, there are issues in the oval window area. There is cochlear aqueduct which is patent, or there is abnormality in the fundus of the internal auditory canal. And in those cases, we should better not to do the surgery. Floating foot plate is a condition where while making the fenestra, the foot plate goes down into the foot plate, and the foot plate goes down into the vestibule. And here, if you can manage, if you can see that the foot plate is very thin, we can use a vein graft and then apply the prosthesis. If the foot plate is thin, the success rate is near about 95%. But if the foot plate is thick, the success rate is near about 50%. So in floating foot plate, laser is the ideal choice. But if there is no availability of the laser, we can try to remove the foot plate by making a pothole in the promontory adjacent to the annulus of the foot plate, and there by inserting a pick and trying to hook up the foot plate. But if it is not possible, or if the surgeon is not very much comfortable of doing that pothole technique, the surgery should be abandoned, and after 4 months the surgery can be done again. Now there are some complications, post-op complications of otosclerosis. Number one is facial palsy. Usually this is a very rare complication of otosclerosis. Mostly the facial palsy is, the immediate facial palsy is due to the infiltration, the local anesthesia. It goes more into the stylomastoid foramen area, and which causes facial palsy, transient facial palsy, which gets all right by the evening. Number two is chorda tympani dysfunction. I already discussed that stretching of the chorda tympani nerve causes more problem, taste abnormalities, metallic taste, dysgeusia. And in patients with bilateral otosclerosis surgery where chorda tympani nerve is resected in both the sides, the patient may complain of ageusia or the loss of taste. Otosclerosis patients may develop acute otitis media after the surgery. The same kind of treatment is followed as we do in acute otitis media. Vertigo, the patient may complain of vertigo due to the serous labyrinthitis. or non-suppurative labyrinthitis. If it is a serous labyrinthitis, the vertigo goes in 2 to 3 days, and we can give prochlorperazine or betahistine or other vestibular sedatives. Reparative granuloma and perilimb fistula I am coming later on. Conductive hearing loss in postoperative period may happen due to the migration of the prosthesis. If it is a loosely fitting, the prosthesis goes out of the incus and fall into the medullary cavity, or in long term, it can lead to the erosion of the long process of incus, and it can cause conductive hearing loss. Or the prosthesis may get adhered to the surrounding structures, can give rise to conductive hearing loss. Now coming to reoperative granuloma. The patient complains of sudden deterioration of hearing 1 to 6 weeks after surgery. Hearing loss is associated with vertigo in 25% of the cases, and in some cases tinnitus is also a complaint. If the granuloma reaches up to the tympanic membrane, the posterior superior area of the tympanic membrane looks reddish in color. The bone conduction is more affected, that means sensorineural hearing loss happens more. The speech discrimination score goes down. The treatment is, before treatment, where it happens mostly in the patients of stapedectomy, not in stapedotomy, where fat or gelatin sponge is used. It causes non-suppurative labyrinthitis, and immediate surgery as soon as possible should be done, where the TM flap is elevated, the granuloma is identified, it should be removed. A regrafting is done, the graft that should be removed, and a regrafting should be done with either with perichondrium or a vein graft, and the prosthesis is also discarded and a new prosthesis is used. Now perilimb fistula after doing stapes surgery is can happen. This is the primary and secondary. Why it happens? It is due to the inadequate sealing, if there is a long prosthesis, or if the pressure of the perilimb is increased, then perilimb fistula can happen. So it can be primary or secondary. Primary when it happens just after the stapes surgery. The patient complains of sensorineural hearing loss, no hearing improvement, or hearing loss if it is after a week, tinnitus, vertigo. The prevention is by making small fenestra technique, that is stapedotomy technique, using tissue graft seal, and prosthesis should be secured. Gel foam or gelatin sponge should be avoided as much as possible to prevent perilimb fistula, primary perilimb fistula. In post-operative time, the patient should be advised to avoid trauma, heavy weight lifting, sneezing, coughing with closed mouth, barotrauma, sudden exercises or sudden movement. This should be avoided. This is a surgical emergency. Again, the anterior tympanotomy is done. That means the tympanomeatal flap is elevated. The fistular tract is excised. The prosthesis is removed. A fresh tissue shield is applied, and a new prosthesis is given. Secondary happens if we follow up our post-operative otosclerosis surgery, stapes surgery patients for a long duration. In those cases, we can also see that some of the patients are presenting with hearing loss, tinnitus, and vertigo. And most of the time, if the hearing loss are sensorineural, then the diagnosis of secondary perilimb fistula is made. So revision surgery is for immediate or delayed conductive hearing loss. We already discussed. For symptomatic perilimb fistula, already discussed. Results is query. Yeah, if it is detected early, the perilimb fistula, primary perilimb fistula, if it is detected very early and the surgery is done very early, that the result is good. But if the diagnosis and the further treatment, that means removal of the fistular tract and application of new prosthesis and graft is done After some time, then the success rate goes down. I have forgotten to discuss one thing. One thing I forgot to discuss, that is this one, this CSF gusser treatment. Yeah, how to manage the CSF gusser or perilymph gusser. I don't think that I said about that. So how to prevent how to manage this CSF gusser or perilymph gusser if it happens in the OT table? If you have not done the CT scan, you have not managed to pick up the cochlear aqueduct patency or abnormality in the fundus IAC, and you proceeded with the surgery in the OT table, you made a fenestra and the CSF started coming, how you should manage? So head end should be propped up, a lumbar drain is given, a tissue seal is applied, and most of the time always try to go for small fenestra technique, that is stepidotomy technique in place of stapedectomy technique. That should not be done. Sometimes it happens while removal of the stapes superstructure, but that is very rare. You should be very much careful while fracturing the crura or cutting the crura. There are different modes of doing crurotomy. I already discussed, with PEEK, with crurotomy Caesar, with laser, with drill. There are 4 techniques that we can follow. Most of the time, surgeon uses a PEEK technique. PEEK, with a PEEK, he pushes the posterior crura towards the promontory, and both the crura gets fractured, and then he removes the stapes superstructure. So with this, I conclude my talk on otosclerosis. I will conclude after showing you a video of back, stop sharing here. Let us start from the beginning. I'm not showing you the tympanomeatal flap elevation, which has been done. Now you can see the posterior superior bony overhang being curated. Now here you can see the long process of the incus. This is the incudostapedial joint. This is the stapedius tendon. This is the chorda tympani nerve. This is the tympanomeatal flap, which has been elevated and kept anteriorly, and this is the horizontal facial canal. And you can see the otosclerotic focus here. So let's proceed. Now I'm using a stapes gauge and I'm measuring. After measuring, I am making a fenestra. I have taken a stapes footplate perforator and trying to make a fenestra in the posterior part of the oval window. You can see the control hole made. Now I will dilate the control hole with a bigger size of. Now can you see? Yes. Can you see the fenestra? The big enough with intact assembly. This is known as reverse stapedotomy or reversal of step. This was advocated by Ego Fish, as I told you. So now I will put the piston. I do with one hand. On my left hand, I hold the endoscope, and with my right hand, I do the surgery. So I'm closing the piston now. Now the piston is applied over the long process of incus. After that, I will close the piston with a crocodile forceps. Usually crimper is available. I do not have a crimper, so I'm incising, sectioning it near the pyramidal eminence. And then you see, this is the way to fracture the posterior crura and the anterior crura. This is the anterior crura. Now this is the stapes superstructure. Then I am taking out. The longer one is the anterior crura, and the shorter one is the posterior crura. The longer one is the anterior crus, which is long and thin. The posterior crus is shorter and thicker, and the stapedius tendon is attached to the posterior crus. So after that, I do my surgery under local anesthesia. So I check hearing after each and every stapes surgery, and after that I put a medicated gel foam and close the ear canal for 3 weeks with all the precautions. With this, I conclude my Hello, sir. So with this, I conclude my talk on otosclerosis.
So thank you very much, Dr. Sabyasachi, for the presentation, and thank you very much,
Thank you very
trainees
much,
and
sir, and
faculty
thank you
members
the
for
National
joining.
Board of Examination for giving me this opportunity. This is one of the most favorite topic of mine. My sir was Professor Barin Raichaudhuri, who is a stalwart for STEPI surgery, otosclerosis surgery. He himself has performed more than 1,000 surgery, and I have also done more than 500 STEPI surgery till now. So this was my favorite topic since my post graduation.
Thank you, sir.
You're welcome.